Hello and welcome to our Lunch and Learn Symposium here at RSNA 2020, where you'll hear about how Canon Medical Systems is using artificial intelligence AI to provide total clinical collaboration with our imaging partners. Our panel today consists of industry and clinical professionals who will discuss this comprehensive solution that is delivering a total end-to-end workflow solution using Canon technologies. I'm Dr. Ravi Shrestha, General Manager and Senior Director of Global Healthcare IT here at Canon Medical Systems Corporation, and I'm very happy to introduce our esteemed panel here today. Joining us first will be Dr. Rich Mather, who is the President of Canon Medical Research USA. Rich will be sharing some insights into our AI suite and the concept of total clinical collaboration. Following Dr. Mather, we'll hear from Dr. Eldad Alencave, a practicing interventional radiologist and the Chief Medical Officer of Zebra Medical Vision. Dr. Alencave will provide an overview of Zebra's platform and highlight how Zebra and Canon have partnered together to transform patient care with the power of AI. Following Dr. Alencave, we'll be joined by Dr. Kenneth Snyder, an Associate Professor of Neurosurgery at SUNY Buffalo School of Medicine and Biomedical Sciences. Dr. Snyder will present the clinical component of our symposium today by sharing his own experiences using these solutions in a busy clinical environment where every second counts and where he is managing his stroke patients. Dr. Snyder will be supported by Ryan Rava, one of the PhD students within Dr. Snyder's team. Mr. Rava will deliver his experience in undertaking the field test of the automation platform and auto-stroke solution at Gates Vascular Institutes and the outcomes of the evaluation studies. Finally, we'll conclude with a short Q&A, which Tim Joseph, our Manager of Strategic Development for Healthcare IT here at Canon Medical Systems USA, will moderate. So I hope that you will enjoy hearing from the panel we have assembled here today, and please feel free to save any questions that you have for our live Q&A sessions following the talks. I'll now turn it over to Dr. Rich Mather to kick things off.
I'm Rich Mather, President of Canon Medical Research USA. At Canon Medical, we use the term collaborative imaging to describe our complete solution for delivering integrated patient-centric care. From acquisition to analytics to seamless integration across all networks and vendors to decision support for intelligent diagnosis and treatment, collaborative imaging fuses multiple diagnostic modalities with leading clinical applications to deliver holistic and optimized patient information into the hands of every healthcare provider where they need it, right at the point of care. We do this in two ways. On the acquisition side, ACE technology reduces noise while preserving spatial resolution and texture in all our images. And our automation platform categorizes, analyzes, and delivers intelligent insights to streamline and enhance critical patient care decisions. While value in medical imaging is a combination of cost, risk, speed, and accuracy, there's one key factor that influences all of them, and that's image quality. Improvements in image quality can lead to lower dose, quicker diagnoses, greater diagnostic confidence, faster exams, and even shorter hospital stays. By maximizing the value we extract from our images, we can minimize costs, risks, and the time it takes for our partners to practice informed healthcare and deliver fast, tailored treatments to every patient. And this is why our strategy has always been to focus first on maximizing image quality using deep learning technology. So why do we focus on a deep learning approach? The answer is quite simple: accuracy. Deep learning in AI has fundamentally changed the way algorithm designers approach challenging and complex problems. Let me give you an example. With the traditional approach to facial recognition, designers would create algorithms that relied on a small number of carefully crafted metrics or features they believed could differentiate one face from another. The distance between major facial landmarks, for example. The success of the algorithms was dependent on how many of these different features could be defined, how precisely these features could be measured, and critically, how well the weights of each of these features were tuned and balanced. Ultimately, the best traditional algorithms in the world reached an overall success rate of about 60%. Not bad, but far from good enough. With deep learning, we turn this problem on its head and allow the algorithm to discover or learn which features are important to the task by feeding it vast amounts of training data. This allows the neural network to measure a far richer array of features in the image and to automatically accomplish the complex task of balancing the relative weights of them all, something that would be impractical, if not impossible, for a human to do by hand. Time and again, this approach has been shown to allow success rates above 97%. It's the same exact story in medical imagery construction. For years, we have designed carefully balanced algorithms that have, frankly, done a pretty good job at producing high-quality images from a fairly noisy input. That said, clean edges and natural image texture have been elusive. With deep learning reconstruction, the network learns all the statistical features that differentiate the signal from the noise and creates images with natural texture and smooth edges while maintaining high spatial resolution and excellent low contrast detectability. And here's a good example of that difference. The low-dose lung scan of a patient with lymphoangioleiomyomatosis. It shows really good noise suppression overall and decent contrast definition with a hybrid iterative reconstruction technique. However, you can clearly appreciate the roughness of the edges and the splotchiness of the texture. With ACE, however, both are greatly improved while preserving the spatial resolution and contrast. In this example of a very low-dose chest, abdomen, pelvis scan, the ACE image clearly shows exceptional image quality with good edges, texture, and very good noise suppression. Of course, CT is not the only modality that benefits from deep learning. Canon's MR-ACE offers tremendous benefit over conventional reconstruction. The subtraction images here show that the edge loss is typical with noise reduction is avoided in ACE. In fact, the signal that we get from applying ACE can make it difficult to differentiate scans taken at 1.5T with ACE versus those taken at 3T. Can you tell which one's which? With ACE and MR, you can also push the envelope on spatial resolution to achieve exquisite anatomical detail within reasonable acquisition time. And finally, we're introducing ACE for PET as well. On this scan, with only a 7.7 millicurie injection on a patient, fairly large patient that is, with a BMI of 30, we see that ACE significantly reduces the noise compared to OSEM with a Gaussian, as well as much better lesion definition. You can see they pop really well here. And finally, a increase in SUV of 28%. We're really excited about this PET algorithm. Using the expertise we gained creating ACE, we've developed a deep learning spectral reconstruction algorithm that powers our PRISM 16 centimeter spectral CT. This spectral reconstruction creates deep learning views that complete the high and low energy sinograms, processes the material decomposition, and creates the spectral images. With Canon's approach, we can take full advantage of automatic exposure control with the rapid KD switching all the way up to 16 centimeters of Z-axis coverage, and this is unique in the industry. And of course, with deep learning spectral CT, we can improve visualization, like in this example of better plaque delineation with monochromatic analysis. We can improve characterization, as in this gout example of identifying the monosodium urate in the metatarsal phalangeal joint. And finally, in quantification, in this example of iodine uptake in the spinal metastasis case. At Canon, our AI strategy extends well beyond our roots in image quality. We're leveraging our deep learning expertise to streamline the entire clinical workflow. We recognize that a well-designed AI can play a critical role in automating image processing and categorization, image analysis and abnormality detection, and work list prioritization and management. This is exactly what our automation platform does, rapidly, behind the scenes, with no required interaction or supervision. The output of the applications on the automation platform is something that we call the insights results. These are the key data organized, packaged, and delivered to the multidisciplinary care team at the right place and right time to make sure that critical patient care decisions are done with the right data. Conventional workflow usually looks something like this. After image acquisition, the data is transferred to a 3D lab where a technologist gathers, selects, loads the relevant data, performs advanced visualization analysis, prepares the results, and sends them off to the clinician for interpretation. With the automation platform, the majority of this work is done behind the scenes, as soon as the scan is completed. With 0 clicks, the AP processes and categorizes the images, performs the needed analysis to triage and detect any abnormality, packages the key findings into insights results, and sends these to the care team prioritized and with alerts for urgent findings. With AP, we really help by reducing the burden on the entire imaging staff, increasing departmental productivity, and ultimately saving time where it's needed most. Our auto stroke solution is one such automated workflow. It receives images from the PACS and directly from the CT system, analyzes for intracranial hemorrhage and large vessel occlusion, as well as automatically performing a full perfusion analysis. Once complete, the findings are formulated into an insights results package and sent directly to the care team, to the PACS viewer, or even to a mobile viewer. And here's a sample of what the care team would see. A summary of patient information and study information, including the critical data such as what scans were performed and when. Furthermore, key analysis results are quickly summarized with abnormal findings clearly called out. In this case, there's the suspected LVO, and the representative image is shown alongside. Finally, a summary of the perfusion analysis shows the volumes of the penumbra and core, as well as the volume mismatch ratio between the two. Drilling down, we find more details of the suspected LVO, as well as details on the perfusion findings, showing the extent of the penumbra and core, and the details of each of the perfusion metrics, and finally a review of both the automatically identified arterial input function and the motion analysis, and this can help the facility to facilitate study quality control. Brought all together, the AP workflow looks like this. The image data comes to the automation platform through standard DICOM and are processed by the relevant application, in this case, AutoStroke. Within just a few minutes, the insights results are emailed directly to the care team as alerts to allow the fastest possible access to the key information wherever the team members happen to be. Simultaneously, the analysis is encoded into a DICOM structured report PDF and available on the department's diagnostic viewer via the PACS. Also simultaneously, the results are routed through a mobile edge device and a web server to be available via a mobile viewer. In this way, we ensure the maximum availability of key data so the care team can save lives when every second counts. Canon's collaborative imaging philosophy delivers intelligent devices with IQ optimized by deep learning reconstruction to maximize the benefits of automated analysis. Intelligent categorization orchestrates the automated processing to get the right data to the right intelligent algorithms, which then use zero-click analysis to deliver intelligent insights, which are turned around in just a few minutes. All this allows augmented decision support, speeding up the time to decision and freeing our clinical partners to focus on the right care for patients everywhere. Thanks so much for your time.
Rich, thank you so much for sharing your experience on total clinical collaboration using AI within Canon. We'll now hear from Dr. Eldad Elenke from Zebra Medical Vision on how Zebra and Canon are transforming patient care with the collaborative power of AI.
Hi, I'm Dr. Eldad Elenke, the founding Chief Medical Officer of Zebra Medical Vision, and I'm very excited to share our partnership with Canon in transforming patient care with the power of AI. We're a company which was started in 2014 with the goal of developing automated, fully integrated AI solutions in medical imaging to diagnose a variety of clinical findings and provide radiologists alerts at the point of care. We have, over the years, recruited more than $50 million of investment with large strategic partners. We have over 90 employees in bases within Israel, the US, and India. And we are actively involved in the academic community in publishing peer-reviewed articles, papers, most recently Nature Medicine +1 in 2020. Our database is comprised of over 30 million patient records with over 500 million images and 10 years of patient history. We have heterogeneous data from across ages, ethnicity, gender, and the data comes from across the world, including from Intermountain Healthcare in Utah, across Israel with Clalit, and Apollo Healthcare Systems in India. The clinical value in our work is to empower radiologists, but also radiographers, people at the point of care acquiring the images. The goal is to provide more accurate detection, faster detection, essentially a safety net in the case where diagnoses could potentially be missed. And importantly, we want to be sure that the insights generated are translated into actual impact and changes in the quality of care delivered. I'm going to talk about our health pneumothorax algorithm and product. The goal of this is to immediately detect the presence of a pneumothorax at the point where the image is acquired. So the product automatically identifies findings which suggest pneumothorax based on CR or DR scans and outputs an alert. This is ideal for radiologists and for additional clinicians who are reading chest x-rays, including those in the ER and other specialists. It takes about 30 seconds to detect the pneumothorax using the software, and this should provide increased confidence for anyone reviewing the imaging, and it's especially useful in nighttime coverage, and I'll give an example of what I mean. Most of us as radiologists are familiar with the circumstance where there are images acquired at night, there is no coverage, and let's take for example the situation in the ICU where you have patients who are being ventilated, so positive pressure ventilation. A scan might be acquired at 3 a.m. in the morning. Now with Zebra, the image is analyzed immediately. Within a minute, the identification of the pneumothorax is made, and minutes thereafter there can be treatment involved. Now let's take that scenario and look at what happens in many places. 3 o'clock in the morning, there may be a resident on call, there may be an attending on call, but dealing with ultrasounds, CTs, MRIs, and very often those radiographic images are not reviewed until the morning, 4 or 5 hours later. Now certainly in the case of positive pressure ventilation, that pneumothorax can grow significantly and cause tension, and there can be downstream repercussions clinically. The goal here is to allow an immediate alert and treatment, saving time and improving outcomes. And so the primary benefit is faster detection. Again, a safety net, making sure that nothing is missed. Pneumothoraces are among the harder findings to make, especially when they're small on chest x-rays. And finally, making sure that those insights are actionable through efficient reporting. And let me talk about that for a moment. How do we make sure that that insight of a pneumothorax is acted upon appropriately? There are three possibilities. We can provide a secondary capture, which is added to the study in the PACS to indicate the finding to a radiologist. We can also output an HL7 message that can be sent to the PACS and enable prioritization of the work list so that, especially in a given setting where there are many studies and the list gets long, this study is prioritized and can be looked at sooner. We can also send out an email notification or a secondary notification directly to the people who are at the front working with the patients in the ICU, in the ER, so that they're immediately made aware of the finding and able to act upon it. So again, going back, immediate identification, better identification, more accurate, and the ability to make sure that it's acted upon right away. The broader perspective, we have, as a company, Zebra has 6 products which are FDA approved, 3 in the domain of CT, 1 in mammography, and 2 presently in chest x-ray, and that's growing. So currently, we have the ability to detect and to act upon pneumothoraces, and also pleural effusion. And we have a range of products that are in the pipeline now to be added to this. The goal ultimately is to allow essentially the radiographer and the radiologist the ability to identify key findings right away. Chest x-ray is the most commonly performed radiographic study. The volume is high. In times like this, it is absolutely overwhelming. And the goal here again is to identify, help prioritize, and make sure that we can act immediately upon those critical findings. I'll end with that, and thank you for your attention, and thank Canon for the opportunity to work together, software, hardware, and a team to ensure that we're using AI to benefit the healthcare system, make it more efficient and more effective. Thank you.
Dr. Ellen Cave, thank you once again for sharing an inside look at the work you and your team at Zebra are doing and how partnership like ours can have a real impact today on patient management and clinical workflow. I would now like to turn it over to Dr. Kenneth Snyder, who will share his experiences using the AutoStroke platform, which integrates everything that you have just heard from Rich and Eldad at his facility in Gates Vascular Institute in Buffalo, New York. Dr. Snyder, please begin.
I am Dr. Kenneth Snyder. I want to thank RSNA and Canon for the opportunity to present to you on an automated platform for collaborative imaging for the treatment of acute ischemic stroke. I'm honored to have one of our PhD candidates, Ryan Rava, join me, who's underneath Dr. Sifri and Ayanita, one of our lead PhDs in the Canon Stroke and Vascular Research Center. With that, I'll jump right in. These are my disclosures. So in Buffalo, we do over 2,500 CT perfusion scans a year as a comprehensive stroke center. We also serve over 14 other institutions, some of which do not have an extensive amount of stroke expertise. Because of that, we've been fortunate that we have automated platforms that live on their CT and imaging scanners and are able to port to us automated when they're able to identify an LVO. This allows us to interact with the emergency room, look at imaging, and make a decision to send a patient over to us for thrombectomy, usually before their virtual radiologists have even had the opportunity to look at a scan. And so there are times, depending on how far away that institution is, that I'm able to call my team in and be ready faster than sometimes when someone comes directly to the institution. That said, when patients do come directly to the institution, having a platform that lets me be able to interact with the data and make a read within minutes allows me to make a decision much faster than the 15, 20-minute turnaround from some of these automated platforms. The critical components of these platforms are ruling out a hemorrhage, identifying whether or not there's an LVO, having an automated aspect score, and identifying a core size of calculation in terms of how much dead tissue is with or without a penumbra ratio. It's very exciting that within our lifetimes, the paradigm treatment of stroke is changing. And it's very exciting for me as an endovascular neurosurgeon to have been a part of this paradigm shift. The guidelines are updated yearly. And so in going through the guidelines and imaging criteria, what's critical are a few key facts. Number one, we need vessel imaging before we make a decision about thrombectomy. Unfortunately, when we did randomized controlled trials of medical versus surgical treatment of stroke in 2013, we did not have this component. What was happening is patients that didn't have a large vessel occlusion were getting randomized for thrombectomy. Second feature of this is that we can't let the imaging slow down giving TPA. If the patient arrives in 4.5 hours, TPA is critical, but we need the vessel imaging then right after. Some of us have moved to being able to give TPA right in the scanner, right in the imaging suite. Next is if there's no history of renal impairment and you don't have a creatinine, there's good level evidence of just moving forward with the vascular imaging. We cannot let this delay treatment. And often we'll get calls to have to override it if necessary, but now we've got good evidence of just proceeding. The next is getting extracranial vascular imaging if possible. When we plan the thrombectomies, having that extracranial imaging is very helpful in how we plan the technique or approach for the thrombectomy. The other couple criteria are consider using a collateral flow score. And right now, none of the automated platforms do this. The ESCAPE trial, I think, did a very good job of showing us that aspect score plus collateral score is almost like a surrogate for perfusion. So for the outside institutions that aren't perfusion capable, adding an automated collateral score is exceptional, and it only needs to be a dichotomous score. And then lastly, what's critical here is that the 2015 randomized controlled trials had mixed imaging criteria for them. And the main guideline update was that you don't need physiologic imaging for less than 6 hours. This is a very dense slide, but it basically shows all of those 2015 randomized trials of TPA versus mechanical thrombectomy. And the fact that Mr. Clean used no advanced imaging whatsoever, not even having an aspect score requirement, and still had a positive result of improvement in MRS or independence, is why there is no criteria for perfusion imaging in less than 6 hours. That said, the trials that did use perfusion imaging to look for vast amount of viable brain had the best outcomes. Nearly 70% of those patients were sent home independently. As I pointed out previously, ESCAPE was the only one that used the collateral score and actually was the only trial that had a mortality benefit in addition to that morbidity improvement in sending more patients home independently. The key criteria of these platforms then is ruling out hemorrhage, identifying LVO, identifying an aspect score, and ideally having an automated component for that, identifying viability or the amount of core dead tissue, and I would love to see an element of collateral score added to these platforms. With that, we'll speak about Canon's automated platform system.
So as Dr. Snyder mentioned, the first thing that should take place in any sort of stroke workflow is ruling out a hemorrhage. So the first application within Canon's automated platform is finding the actual hemorrhage within an image. What happens is a non-contrast CT is fed into their platform, and then it's whether or not the slices actually contain hemorrhage or not. The artificial intelligence algorithm that was trained for this was trained on over 10,000 cases and 35 different scanner types, and then it was validated on 850 scanners, or 850 cases and 41 different scanners. Then just some the metrics that they had on an internal validation set. The algorithm shows a 96% accuracy and a 97.5% sensitivity, and shows a computation time of approximately 20 seconds. Now here are some of the actual cases that we've fed into the algorithm and done with our own study. As you can see, it does in fact find each type of hemorrhage when actually looking at each of the non-contrast CTs. You can see the intraparenchymal, subdural, intraventricular, and subarachnoid here. And then looking at some of the other currently available software, you can see that Rapid has its own artificial intelligence algorithm for ICH detection with a slightly lower sensitivity than the Canon platform. And then Viz.ai also has its own automated platform where it actually pushes the results to a clinician's phone following receiving the results. So the second application within Canon's automated platform is a large vessel occlusion, or LVO detection. This algorithm is again artificial intelligence based. It was trained on more than 3,000 cases and validated on 450 cases. So the actual output of this is the CTA scan, and then through the actual scan, it will identify which slice in the scan actually has the occlusion present. The actual metrics from an internal validation show a 98% accuracy and a 98% sensitivity. And again, the computation time is roughly 20 seconds for this algorithm. And then again, here are just some example cases that we ran on our own study, mainly focusing on the first case here. You can see that there is a right internal carotid occlusion on a 46-year-old female. Particularly, you can see in the coronal view that the ICA occlusion is rather relevant here. And then some more currently available software. Rapid and Viz.ai also have their own artificial intelligence algorithms. Rapid offers a 97% sensitivity in actually locating the occlusion, and you can see that there's also a blood vessel density overlap indicating where there is reduced density and where there is increased density.
When we look at how the guideline then deals with cases that show up after 6 hours, so the 6 to 16 and 6 to 24 extended time frame windows, this is when the perfusion imaging is critical and is necessary in order to select patients. Based on the two trials of Diffuse 3 and Dawn, there are clear guidelines of selected treatment that make understanding the amount of core critical. You can see the criteria used in both of those trials in terms of NIH differences and age differences. The presenting time frame of 6 to 16 hours for Diffuse 3 and 6 to 24 for Dawn. Within Dawn, they did not calculate a penumbra. They used clinical exam as the core feature of assessing salvageable tissue. And they used a core estimate. If someone was greater than 80 years old, the core needed to be less than 20 to be eligible for that trial. If they were less than 80 years old, there was a NIH gradient of what size core was allowable for treatment. And for diffuse 3, they did calculate a penumbra based on time delay, and they had a ratio of 1.7. So if you don't have your own internal institutional IRB for studying anybody outside these windows or pushing the envelopes of these treatments, these are the core guidelines that are listed for treatment for acute ischemic stroke. The question then becomes, if you're not using rapid, how do these relate, and how do these thresholds match? Rapid makes calculations of penumbra of anything greater than 6 seconds out. Its decision-making on core is based on cerebral blood flow of less than 30%, so 70% reduction, or a Tmax of greater than 6 seconds. The thresholds used have changed over multiple trials. The latest is the less than 70 cc's and mismatch greater than 1.8. The importance of these core calculations can't be overestimated. This is how we decide who to take or not. We're very fortunate here in that we have access to all available platforms. This allows us then to take the same raw DICOM data set and process it over multiple vendor platforms and actually compare them. So our idealized data sets are CT perfusion scans followed by very rapid thrombectomy, ideally to TICI-3 or complete recanalization, with a flare image done at 3 to 5 days, and as that being defined as final infarct volume. Comparing that then to the original perfusion studies, we're able to assess and compare different thresholds and optimized thresholds. Ryan?
So as Dr. Snyder mentioned, getting the core estimation is essential in order to determine who is actually thrombectomy eligible. Now, we've done a bunch of different collaborations with Canon in the past and used their previous Vitria software, and now we have also validated their new CTP Plus software, which will be included within Vitria and their automated platform. So in the image on the left, you can see that there's a ventricle segmentation for both software, with an improved segmentation for the CTP Plus software, removing erroneous infarct from the ventricles. They've also improved the contralateral hemisphere thresholds in order to remove erroneous infarcts from the contralateral side of the stroke. And then they've also improved the arterial input selection and venous output selection to improve the distance between the curves. Now here's an example case comparing DWI infarct, the new CTP Plus automated platform infarct, and a rapid infarct. And as you can see from this case, there's a right ICA occlusion, and the actual CTP Plus infarct more accurately matches up with the DWI compared with the rapid infarct. So some of the current CT perfusion software out there are Rapid and VisAI, where VisAI will analyze the data and send the actual core and penumbra estimations to a clinician's phone, and then Rapid will actually take the data, push it off-site. It will be analyzed and sent back, which can take roughly 15 minutes. Meanwhile, Canon's automated platform will take approximately 6 minutes to process the data and give the clinicians their results. And as I've mentioned before, a bunch of different collaborations with Canon. Having the clinicians on site is also helpful. We've been able to build a huge data set of DICOM volumes for CT perfusion. We've been able to compare Canon's singular value decomposition and Bayesian algorithms for CT perfusion. And we've also done volume comparisons and spatial overlap of estimated core volumes with actual follow-up flare and DWI volumes. And then here you can see our upcoming publication in the Journal of Neuroradiology, which is an actual comparison of the most recent automated platform CTP Plus algorithm compared with rapid oleosphere and DWI infarcts.
This is a very complicated case, but I think it points out that guidelines are only guidelines, and we have a great deal still left to learn. And again, having our institution with an IRB to study outside of guidelines is how we're able to do what we do. This is a 28-year-old that presented with an NH of 21, just within a 4.5-hour window, so they were given TPA. We had a hypermedia sign on the left, patient had a left M1 occlusion. The volume calculations were that there was nothing salvageable and that the entire territory had cerebral blood volume drops of less than 30%. By guideline, this patient would never have been selected for treatment. The fact that the patient was 28 in just under 4.5 hours, we made the decision to move forward anyway, realizing that these are probability estimates of what happens to that territory. When we went up, we were surprised to find an ICA occlusion, so there was progression of thrombus compared to the preoperative imaging, non-invasive imaging. So now we've got I see occlusion. We went up with an aspiration system and aspirated our way through the occlusion all the way up through to the petrous segment. We had residual clot left, but there was flow. Without dealing with the clot, we went up intracranially and dealt with an aspiration intracranially, and we were able to revascularize the territory. The minute we revascularized, the patient complained of massive headache and started throwing up on the table. Obviously, we were worried with TPA on board with that amount of tissue that could be dead tissue that we hemorrhaged the patient. We immediately intubated the patient and then did an on-table low contrast CT, and thank God we did not see any hemorrhage. So then we accessed the patient, went up and did some imaging, and we saw that the patient was reoccluding and had severe limitation in flow, a lot of thrombus within the ICA. We went up and actually stented. We gave Brilinta, stented, put 2 closed cell stents and stented from the petrous segment down. On the AP, we still had a significant element of stenosis into the intracranial cranial portion. And therefore, we needed to actually put further stents in, a wingspan stent, over that region. So after that stenting, we looked intracranial. Things looked good. We had, again, TPA on board, and then we had Brilinta on board. And then on the way out, we took one final look and realized the wingspan stent looked like it was getting clotted off again. Looked up at the head, and we were losing the superior trunk. At that point, we made a decision to give a half a bolus of integralin, open things up a little bit, but not perfectly, and then gave a full bolus of integralin to finally open things back up again. So here we've got a 28-year-old person that got TPA'd, heparin, Brilinta, aspirin, and integralin. We did not expect this person to survive. The final CT showed no hemorrhage. The MRI showed a very minimal flare change, and thank God that patient's NH dropped to 4 and was an MRS of 0 by 1 year later. Somebody that, based on any of the trials, should not have had that good of an outcome. Again, it speaks to we've got a great opportunity of continuing to push the envelope of this field. Currently, we use our perfusion studies to actually tailor the treatment for individuals. This is a person that was already showing reperfusion hemorrhage in a distal territory but had a basilar occlusion. In those cases, we go up and we occlude the territory beyond where the thrombus is and then come back and take the clot out. So this is opening up a basilar terminus but shutting off the tissue that was already showing reperfusion hemorrhage. We also are publishing in radiology, neuroradiology, an E-aspect score to really objectivize and automate that scoring system post-thrombectomy. We're very excited about getting the 4D CT system to allow us to do on-table perfusions of selective and single vessels and do 3D calculations to compare to our preoperative perfusion set. With that, I'd like to thank the entire Canon Stroke and Research team and Canon itself for the collaborative work. We're greatly appreciative of the support and honored to care for the patients that we serve.
Dr. Schneider, we really appreciate your clinical insight and participation today, and for sharing how these tools are making a difference every day at your institution with patients and making a difference to patient care. We'll now turn it over to Tim Joseph, our Manager of Strategic Development for Healthcare IT here at Canon Medical Systems, who will moderate a short Q&A where we'll get through some of the questions that have already come in. But before I do so, I'd like to once again thank you for joining us today, and I hope that you've enjoyed this virtual symposium here at RSNA 2020. For more information about our AI technology and the rest of the Canon portfolio of solutions, please visit Canon Medical's RSNA experience. Thank you very much.
Hello, and welcome to the question and answer session for today's Lunch and Learn. I would like to extend my sincere appreciation to all of the presenters for their time invested to bring these topics forth. We can now start the question and answer period. We already have questions coming in. I believe this first one is for Dr. Mather. How soon do you see ACE and other AI technologies to become widely adopted into the mainstream imaging departments? Dr. Mather.
Thanks, appreciate it. It's a great question. Actually, it already is. I mean, this is something that is already making major impact into a bunch of different departments. And for example, ACE in CT is already deployed on almost every scanner that we are shipping right now. And so as you know, this is still relatively early days, but as every scanner goes out, more and more people are using it. And I think that's true also in MR and the other ones. As far as AI, we're already seeing a huge adoption of AI from the sites that are seeing it and using it. They love it. They won't go back. And so I think it's a really steep curve towards full adoption. And like I said, it's already there.
Fantastic. Thank you, Dr. Mather. The second question I'll address to Dr. Ellen Caveye. How are the automated results mostly being used in practice to date, as overreads or compressing time to treatment or work list prioritization?
I would say less as overreads, more as prioritization and compressing time to treatment. The biggest, for the products which are currently available and not in testing, the products that are available, the feedback we get is that these are their pneumothorax findings or their intracranial hemorrhage findings that are identified immediately and can be treated immediately. And that's often we often get that feedback when the case is in the middle of the night or on the weekend, and there's kind of a large list.
Perfect, thank you. The third question I'll address to Dr. Schneider. How fast do you see the automated stroke and other AI technologies getting to the majority of stroke centers across the country?
So I know a good component of the automated platform is FDA approved already. I believe the aspects portion is still in that phase of approval. Once those are all FDA approved, I see this rolling out along with the other Canon technology. We at the beta site have been fortunate that we've been able to test it and continue to test it real time with all of our cases coming in. So I know a vast majority of it's already FDA approved, and those should be available. Once the complete suite is available, then I expect the whole platform to be out.
Perfect, thank you. This next question is for Dr. Mather. How are the sites currently using the AI technology? Is it for dose reduction, time savings, or image quality enhancements?
And the answer is kind of yes. I think the main thing in CT, we'll just start there, it's really for image quality enhancements. We're really looking at our ability to see sharp, clear, distinct images with ACE, and it really shows an enhancement in the overall texture of the image while reducing the noise. So it's for CT, it's mostly around mostly around image quality enhancements. In MR, it's a little of both. So for the 1.5, we're really starting to see them taking advantage of the fact that ACE and MR can give you images that look better than what you would ever see in the 1.5, really approaching sort of the signal to noise that's available at higher magnet strengths. And at the 3T level, we're kind of pushing the envelope, for example, in resolution, where stuff that would never be able to be done in a clinically relevant time frame, we can now do higher resolution scans with the ACE on board and do it in a reasonable amount of time.
Perfect. Thank you, Dr. Mather. The next question is for Dr. Ellen Caveye. What does the final report output look like, and can it be altered in the patient record if needed?
Can it be altered in the patient record? So currently, the products that we have available are triage products. So there's an alert that brings the study up to the front of the list and indicates what the abnormality is. It doesn't automatically populate the report. But having said that, there are other AI products that do that from Zebra, and those are configured at the level of the radiologist. So radiologists can determine how they want that insight to appear in their own wording, whether they want to accept it or reject it.
Okay, perfect, thank you. This next question is for Dr. Schneider. Is the technology, the AI technology for stroke, intended to be used by only comprehensive and primary stroke centers, or could this also be adopted by other facilities, outlier facilities?
I think one of the beauty of these automated platforms is to try and standardize or extend an expertise anywhere that there's a scanner. And so by having an automated platform on any site, remote facilities that don't have expertise, where I see them tremendously beneficial is through the emergency room, a CT scan is done, and automatically that imaging is ported to a centralized comprehensive center with the expertise. As I mentioned, when those systems are set up as hub and spoke models, I'm getting a report or an automation of an LVO even before that outside facility's ever sent the scan for a remote radiology read. It allows me to reach out to that smaller facility, speak to the emergency room doctor, get information, help them with decision making, both cases that may stay local and do follow-up, or cases that need TPA and stay there, or cases that need TPA and shipping. So it allows us to extend the stroke expertise to any facility that has a scanner in an emergency room.
Excellent. I believe this next question is for Dr. Mather. Using ACE, how do you make sure that nobody is missing an important detail or diagnosis?
It's a great question, and it's something that comes up with every reconstruction algorithm technique, really since the beginning of time. So all images are processed, and they're processed heavily, and they're really made to look how they are through very advanced algorithms. It really depends on sort of what your level of truth is and where it goes. But the way we do it is we test. We test very heavily, and we show through training with the AI that it doesn't change the overall texture. It doesn't hide any small individual pieces of key information. And really it's just through careful algorithmic design. But this is no different with ACE than it is with any other algorithm that any vendor is showing. It's always a trade-off and a problem, and not a problem, but a challenge. And we do it through testing, through robust algorithm design, and ultimately just through the fire of using it in the clinic.
Excellent. Let's see, the next question, how far can AI go? Will it be limited based on imaging system or hardware? Dr. Mather, I think that you can probably address this one as well.
It's a great question. I mean, we are still in the very early days of AI. It's showing great promise. And I'll say that we're in the very early days of the latest incarnation of AI. Certainly, this has been around forever. It has risen to great levels of hype and then been knocked down. This time around, I think that's changed a little bit, and we're really seeing some very relevant results from AI. I don't think it's limited really based on imaging systems and hardware. I think it's really going to be based on the data itself and how well we can curate that data, how well we can aggregate that data, and then feed that into the algorithms. And I'll certainly let my other colleagues talk about this some more, but I think really everything that we're seeing right now is data limited more than anything else. I think the hardware will always come, the algorithms will always come, and maybe one interesting thing is we might actually change our imaging systems and the way they acquire data based on AI algorithms. We may try to build systems that are more friendly towards AI rather than human interpretation, or some combination of both, and we really need to find that balance. But I'd be interested to hear what the other colleagues would say about this.
Dr. El-Nakaveh?
It's a tough question. I mean, it's a full discussion. I think, look, on the one hand, fundamentally, the value of the AI is that is produced is a reflection of the value of the data, as Dr. Mather said, that it's trained on. But then, of course, you're really generating something which is based on the past. And so, as image quality or image acquisition, or even parameters of, say, KVP change, you'll need to apply that to something else. I think the challenge is certainly about, if I were to sum it up, I would say that the quality of AI in the future has to do more with how well we adapt to changes in hardware and software and image acquisition parameters that lets you produce even better products within a changing environment. We've seen it now with going from MAMO to TOMO, and from single phase to dual phase CT, and I think it'll be that way in the future.
Dr. Snyder, how about you?
Not my area of expertise, but when I think about a complex likelihood space and I start to think about the correlations that we're not taking into account between different modalities. Things like an aspect score and a perfusion score and an LVO should be correlated, and yet we are not correlating those equations necessarily in our minds. Those are spaces where AI can really help us. It'll help us ask more refined questions. What does the tissue residue impulse function mean, and what does it look like in a capillary bed or a capillary space? Can I start to take three-dimensional brain tissue and capillary beds and embed those into these AI models? I think it opens up my mind more of how far can I push the computers, because there's so many questions we don't have answers to.
Excellent, thank you. Let's see, the next question, has the introduction of AI allowed your facility to treat more patients? Dr. Snyder, I'll address that with you first.
I think you want to partner with as many institutions as you can that do not have capability right now of treating stroke patients to the level of the guidelines. I mean, this is an incredible opportunity of extending care where sadly care has not always been on the forefront. And nothing could pain me more than knowing there might be an individual with salvageable brain tissue or salvageable penumbra and no treatment is offered. And although that occurs globally throughout the world, we shouldn't allow it to occur within the United States. There's enough interventionalists to get their hands on. So the key step in this decision-making is the algorithm and finding the salvageable brain. Getting that disseminated to any and every scanner should be part of our first pass and first path at this. And so again, I just feel very strongly there shouldn't be a limit to the ability for this to disseminate on imaging scanners.
Dr. El-Nakaveh, has it helped you in the treatment or compress the time or increase the number of patients that you're seeing in your practices?
I have functioned as a clinical interventional radiologist, and in that setting, and we have Zebra and installed in our hospital, and I would say that certainly not in IR, but in diagnostic radiology, we've seen we've seen more of our chest X-rays being read, just kind of full stop there, because we haven't been able to read all of our chest. We don't have enough radiologists. But being able to strategize and say, okay, these are normal, these are problematic, the sort of cognitive load of mind switching, going to abnormal, normal, abnormal, that's actually allowed us to read more studies. So the answer is yes.
One feature, if I could, Tim, I wanted to add. It isn't about capturing volume of patients. It's about getting the right patient to the right place at the right time. Nothing worse than having a patient transferred to a center for a big procedure and they show up and the brain tissue is already completely gone. And so one thing it really helps us with is keep people close to home if they can stay close to home and extend the expertise. Bring people to the comprehensive center that need to come to the comprehensive center. It's not necessarily about volume. Sorry, thanks for letting me add.
No, that's a really good point, Dr. Snyder. Thank you. The next question, do you use customer ACE data to improve the existing ACE algorithm? So I'll address this with Dr. Mather. Do you use existing ACE data to improve it?
Not yet. And so it's, only in the sense of looking at sort of feedback, and we're always improving the algorithm overall. But we're not yet feeding that initial ACE data back in. ACE is actually trained on our on a version, kind of a high-level version of our iterative reconstruction algorithm that we could never actually deploy because it just takes too much time to run in the version that it is. And so we can create really high-resolution data sets to train. So in that sense, ACE is trained on customer data sets and run through these high-resolution reconstruction algorithms. But as far as that sort of on-site or even feedback directly from the ACE, not yet, but that's something that we can certainly look at.
Mm-hmm. The next question is, how do we define the ROI for ACE technologies? Patient benefit is definitely there, but how do you justify the cost and convince the administrators? It's kind of a question for a couple of you. Rich, I'll let you go ahead and take a crack at that first.
Yeah, interesting. It's something that image quality is always value. If you are reducing the time it takes, if you're increasing the confidence of a read, if you're just looking at the ability to make sure you make the right diagnosis at the right time, that is an initial value, is always a value, and certainly ACE brings that to you. Certainly dose reduction, speed and MR, all of these things drive the value equation for our partners in the field. And so those are the things that we really see as driving the benefits and the ROI on ACE.
So from the perspective of the second half of the question, how do you convince, and this may not be for you, Rich, how do you convince an administrator that this is actually technology that is useful? Dr. El-Nakaveh, have you had experience with this?
Yeah, I mean, there are two things. So there's kind of anecdotal situations where people tell you, listen, you know, we would have missed that pneumothorax, or we would have read it in the morning. And then there are studies that we do and usually publish on where we can demonstrate either reduction in time or more value obtained per study. So diagnoses made, which would have otherwise maybe seemed circumferential to the reason for the diagnosis, but important nonetheless. I think that AI has a lot of promise in better quality, better time, better efficiency, but also in identifying things that might otherwise go overlooked, but is nonetheless important.
Thank you. And Dr. Snyder, the patient benefit for having AI versus the cost, have you had an experience working with this aspect?
I think related to the one area that will resonate strongly from a quality and patient care perspective is the dose reduction component. As long as we're living in an X-ray world and generating X-rays to generate images, we must be on the forefront of dose reduction, gleaming as much data as we can to minimize the dose. I'm very fortunate that our Angio Suite has real-time dose measurements for my patients on the table. We shouldn't be far from using AI to give us a cumulative lifetime dose of two patients that change in time depending on how many different images of X-ray they get in their lifetimes. Canon continues to and needs to stay on the forefront of this as we are limited by X-ray technology until that changes in the future.
So I see our time is kind of winding down. Any last thoughts, Dr. Snyder, on how you're using this AI technology?
Excited to see it continue to evolve. Excited to fully implement the FDA-approved mobile platform. And it's just nice to see my collaborative partners continuing to push the field in the envelope to get the tools into our hands to treat our patients with the best technology we can. Remembering that the technology can only do so much, but what it allows us to do when we're busy is focus our energy where it needs to be focused. It helps us take this noise of data and reduce our clinical energies to where they need to be. And that's greatly appreciated on the clinical front right now.
Excellent. Thank you very much. I again wanted to thank all the presenters and all of the participants who offered questions that make these events so successful. Thank you very much and have a wonderful rest of your RSNA.